the way that I pulled this particular, I'm not using any of the stock stuff from the textbook or anything like that. I pulled the educational standards, that the minimum competencies or the minimal standards that we as paramedics need to know, that you as paramedic students getting out need to know as entry-level paramedics in concerns to medical emergencies. So all of this stuff is pretty fair game on your exams and things like that. Basically, this is just really a copy and paste of that outline on here as a guide for us to go through and to talk about some things. So the first thing we're going to talk about is pulmonology, and within pulmonology we're going to talk about the actual disorders of respiratory and ventilation. So the first thing we've got to remember with this is that in order for us to have proper ventilation, we've got to have several things. That's going to be an intact respiratory or intact respiratory center in the neuro system, right? Your medulla and your pons, your respiratory system's got to be intact. Your brain has got to be able to have the ability to communicate with your lungs. Your brain's got to have the ability to communicate with your diaphragm. Your brain has actually got to have the ability to communicate with chemoreceptors. And those chemoreceptors have got to have the ability to communicate with the kidneys or with the pons in order to control the acid-base balance, right? You've got to have an intact chest wall because we depend on that negative pressure. So the intact chest wall is going to help us pull that negative pressure because we breathe through a suction mechanism like a syringe. Like when you pull the plunger on a syringe, you're pulling air in, and then we breathe out with a passive process where the lungs have elastic tissue, and the Herring-Brewer reflex is actually instigated where it says, hey, our lungs are full enough, and so we are going to release this air back out. Now, you've got to have an intact neurosystem. You've got to have an intact an intact muscular system, your intercostal muscles, your diaphragm, those kinds of things. Your diaphragm, we depend on our diaphragm to contract and pull down. We depend on our intercostal muscles to contract and push out. And is there a question? You've got to have intact pipes, obviously. You cannot have an obstructed trachea or an obstructed lower airway, the bronchioles. And then, of course, the ventilation is the mechanical process, whereas the respiration is going to be the chemical process. And so you've got to be able to have an intact chemical process, the ability to bring that oxygen in and actually convert it over into the blood as oxyhemoglobin, where it binds with the hemoglobin, and then it makes its way throughout the body. We've also got to have the ability to have the waste product transfer in the form of CO2 once it hits the lungs. So you've got to have all of that in order to have a successful respiration and ventilation. Now, in that case, our disease processes or our disorders are going to be affected through one of those mechanisms. Do you guys remember the VQ or ventilation perfusion match or mismatch, where if somebody's having respiratory issues, breathing issues, we need to figure out what is the cause of this issue? Is it an issue with ventilation, or is it an issue with respiration? Now, of course, there's going to be a root cause, and then there's going to be a secondary cause. For instance, if it's an issue with ventilation, as what we're looking at right here, upper airway obstructions. So eventually that airway obstruction is going to cause an issue with respiration or the chemical of oxygen and waste products. So while we're going through these, and while you're doing your assessment on your patient, while you're doing your assessment on your test, you want to make sure that you're evaluating what is the main issue here, because there are going to be two different mechanisms in which we manage these, right? If it's an issue with ventilation, we've got to figure out a way to get the pipes open or to help with ventilation. If it's an issue with respiration or hypoxia, oxygenation, then we've got to get oxygen into the cells. So with your upper airway obstructions, one of the most common causes of upper airway obstruction is going to be the muscle in our mouth, the tongue. Some of us work our muscle in our mouth a lot more than others. So some folks' tongues is a lot more heavy and a lot more ugly, and it is able to clog the airway a lot better. I'm getting real deep and philosophical right there on you guys. But common causes of your upper airway obstructions, that's going to be the relaxed tongue. And so essentially the relaxed tongue may be caused by something deeper, meaning that it may be, facial paralysis, or it may be an issue with the sympathetic nervous system where we've lost muscle tone. They're unresponsive, something like that. Obviously food for choking, dentures, any other foreign bodies, neck trauma, upper airway burns, allergic reaction, swelling. Now, the important key here with your upper airway obstructions certainly is going to be identifying what is causing this obstruction, because the treatment for that patient, or the management, I like that term better, the management for that patient that is choking on a piece of steak versus the management for somebody that has an upper airway obstruction due to inhalation injury is much different, right? And so we need to be looking for those signs. We need to be looking for that history. We need to be trying to figure out what exactly is happening here. Now, one of the things that is important to remember is that if it is a physical obstruction, if we hear air moving, then at least they are getting air, and we can work on trying to get that obstruction moved, right? If it is an upper airway obstruction due to an allergic reaction or an inflammatory process, your upper inhalation burns, things like that, airway movement is good, but we know that it's going to progress, right? We know that the way the airway goes, and so obviously our modality for treatment is going to be a little bit different. One of the big things that we're going to be looking for in someone that has a upper airway obstruction due to an inflammatory process is going to be what? Stridor. Yeah, stridor. So stridor is very important in this aspect here. Do know that no air movement or silent sounds are terrible, obviously. And then, cyanosis means that we have hypoxemia. Cyanosis means that there is oxygen that is not getting moved in the body, and it's not getting to the cells. As far as management of this patient goes, you're going to have to figure out what the modality is, or what is the cause of the upper airway obstruction. So this is one of those things that, the pipes can get clogged, but the treatment's going to be different, right? I mean, if it's a foreign body, then your only way to really fix that is to remove the foreign body. Heimlich maneuver or compressions, or what else can you do as a paramedic?
Laryngoscope.
Yeah. Yeah, so you can do direct laryngoscopy. Now, as far as management for like upper airway burns, you hear that you know that patient's been in a fire, they've been exposed to toxic smoke or superheated gases, and you hear that stridor. What are you thinking?
The airway's closing up.
Yeah, so it's kind of like that Eminem song. The deal is that you really do only have one shot, because once those tissues become inflamed, any further irritation to those tissues is going to cause an inflammatory process to continue. So you really need to be thinking, hey, is there something that I can do to go ahead and manage this airway? Thinking ahead of I need to see this patient as they may be in 5 minutes from now if I don't do something. Allergic reactions, our very first step, if we notice signs of anaphylaxis, our very first thing after we try to manually manipulate the airway or whatever is going to be to do what?
Epinephrine.
Epinephrine's your drug there, okay? Now, there's another thing that you can do if you have laryngeal edema with epinephrine.
Nebulized epinephrine.
Yeah, so racemic epinephrine. Now, racemic epinephrine is going to work a little differently than injected epinephrine, meaning that racemic epinephrine is going to mainly hit at the upper airway. And now, of course, epinephrine is still going to work the same way once it makes to the lower airway by binding to the beta tubes on the lung tissue. But if we're looking for lower airway opening due to wheezing, then we need to do albuterol and ipratropium, right? And that's part of the anaphylactic process there. But our very first drug in anaphylaxis, when we see one of two things, what's going to be your key to give epinephrine? You see one of two things in anaphylaxis.
Hives and stridor, or wheezing.
Stridor.
Hypotension.
What?
Hypotension.
Hypotension. Now I can deal with the hives a little bit more. I know that that's part of the deal there, but hypotension is there because that's going to give us indications of shock. Now with your lower airway obstructions, of course we spend a lot of time on our obstructive and restrictive airway diseases, trauma, mucus, reactive airway diseases. With your lower airway obstructions, most often that's going to be more of a medical cause than it's going to be of a foreign body cause. Your lower airway obstructions most often are from a medical cause, and so we've got to figure out what the treatment is there. One of the worst ones with lower airway is going to be mucus, especially in situations where it's like emphysema or a reactive airway disease with asthma, because we always talk about the bronchoconstriction with asthma, but we don't mention a lot that one of the disease processes of, or one of the processes of asthma is going to be excessive mucus production as well. Now, remember I said that in order to have a good ventilation, you've got to have an intact chest wall. So if you've got a chest wall impairment there, that's going to affect the atmospheric pressure. That's going to affect the ability for you to get that air in. Spontaneous pneumothorax. Now, it doesn't have to be a sucking chest wound, and it doesn't have to be a tension pneumothorax. Remember, tension pneumothorax is a later sign. Spontaneous pneumothorax can lead to tension pneumothorax, but spontaneous pneumothorax often is unexplained. We don't really know why that happened. Usually it's because a little bleb on the side of the lung wall, and oftentimes it's self-limiting. Pleural inflammation, something like pleurisy or pleuritic infection. The area between the visceral pleura, which is very close to the lungs, and the parietal pleura, which pushes away from the lungs. You know, you got your pleural fluid in between there. Oftentimes with this, you actually have a replacement of the pleural fluid with nothing, and it becomes very sticky, and it becomes very painful. And then certain neuromuscular diseases, such as muscular sclerosis or muscular dystrophy, these things affect the ability of the neurosystem to communicate with the muscles, or there's a degeneration of the muscles. You also may have something like Guillain-Barré, where it starts with paralysis at the bottom and it moves up and the diaphragm becomes paralyzed. What about diffusion, or as I mentioned earlier, respiration? So we've got ventilation and we've got diffusion. And diffusion is going to be the movement of gases, right? The ability of movement of gases across the cell membrane and the capillary membrane. Inadequate oxygen concentration in the air. Obviously, we've got to be able to have a certain amount of atmospheric pressure to keep, remember these terms, partial pressures. Our blood has to have a certain amount of partial pressure of a particular gas in order for us to have good diffusion. Alveolar pathologies. Now, we can see that it may be a physical issue with the alveoli, but because of the physical issue, we have an inability of movement of oxygen across the membrane. Interstitial space pathology. What are some things that may affect the interstitial space? All right, yeah, pulmonary edema, non-cardiogenic or cardiogenic. High pressure or high permeability. Remember those terms? High pressure or high permeability. Now, moving down further, yes, electrolyte imbalances, hydrogen, increases in hydrogen, acid-base balances. Now, ARDS, acute disease or dysfunction syndrome, often a late sign of some inflammatory processes, but ARDS is going to cause issues, several issues here. One of the big issues with ARDS is that it causes increased capillary permeability. It causes increased alveolar wall permeability. And then one of the byproducts of ARDS is excessive mucus as well. So this is essentially a degenerative, acute degenerative issue of the walls of the capillaries and of the alveoli. Now, around the alveoli, we have surfactant, right? Surfactant is very, very, very important when it comes to the ability of the alveoli to open and close. We depend on a increased surface area. So essentially we depend on that balloon to open up and close. And the way that this happens is by that surfactant allowing for almost like a lubrication type deal, but it allows that balloon to open and close. In ARDS or even in submersion and drowning, now there's a couple of steps that happen within the submersion and drowning, but one of the things that directly impairs diffusion is going to be the washout of surfactant. And so like with ARDS and even with submersion and drowning, now of course you've got fluid in the lungs displacing the ability of the air to move in submersion and drowning, but with ARDS it washes out that surfactant and then it causes all the alveoli to collapse. And what does that do? Atelectasis. Yeah, it causes atelectasis. Issues in impairing perfusion. So in this situation, we have the ability to breathe the air in. We have the ability to move the blood or the gas across, but we've got the inability to perfuse the body with it, meaning that this is going to affect your circulatory system more and is going to be issues with really the transport system of the blood. So again, you're looking at the different aspects of the breathing process here. So obviously hypovolemia, if you've got decreased fluid, you're going to have decreased ability to move stuff. Anemia, we greatly depend on hemoglobin. We depend on hematocrit and hemoglobin to perfuse no matter what type of anemia it is. And then impaired circulatory blood flow. What are things that may impair circulatory blood flow? Pulmonary embolism, DVT, things like that. So I've kind of mentioned some of these specific illnesses, acute adult respiratory distress syndrome. With ARDS, remember that there's other terms here, non-cardiogenic pulmonary edema or high permeability pulmonary edema. Oftentimes you'll see ARDS as a secondary issue with somebody that has experienced a toxic inhalation, or one of the most common causes of ARDS, sepsis. So sepsis is part, remember with sepsis you have that whole deal where you start having multi-organ shutdown, and with sepsis the lungs are one of the big things that are affected. I don't know the exact pathology of what's happening with the COVID stuff, but I do know that it is affecting the ability to diffuse gas, and I do know that it is affecting the ability of the lungs to take in air. I think that there's a lot of like gunk and fluid that's being filled up, and one of the things that they're doing with these patients is that they're putting them in prone positioning, and they're also doing like CPAP and things like that where it helps to get that fluid moved and it helps to kind of push the fluid. That's one of the things that with somebody with ARDS, one of the things that you're going to hear are like diffuse crackles, diffuse fluid in the lungs. And for us, if it is ARDS due to sepsis, or even a toxic inhalation injury, we need to realize that in this case, that patient is experiencing this pulmonary edema not because they are fluid overloaded, as in with cardiogenic pulmonary edema, but it's because they've got this buildup of this gunk, this fluid, this junk in their lungs. And so one of the treatments there, the two main treatments for somebody with ARDS in the field is going to be fluids to help break up some of that stuff and CPAP, positive pressure ventilation. With emphysema, which falls under the chronic obstructive airway diseases, you've got two different types, well, three, I guess. You've got, with your COPD, you've got emphysema and chronic bronchitis. With emphysema, this is going to be a destruction in the alveolar walls distal to the terminal bronchioles and is usually associated with chronic bronchitis. The issue with emphysema is that the lung tissue, the cilia, the things that help us breathe, the elastic ability of the lungs, all of these things are greatly affected And in turn, it not only affects the physical ability to breathe, but it also affects the electrolytes. It also affects the ability to perfuse. It affects the ability to get rid of stuff. So with folks that have chronic lung diseases, they're going to be what's called retainers, CO2 retainers. Remember, with your emphysema patients, you're going to see usually a real frail type figure, increased dyspnea on exertion, so that's very important, especially somebody that is chronically ill with this. Their quality of life is very low. They can't make it really from the bed to the chair or the chair to the bathroom without severe respiratory distress. Barrel-chested because of, remember, they're called the puffers. They're barrel-chested because of the increased use of accessory muscles, and then they puff. They use the pursed lip breathing because they are trying to create their own peak. This is also where you may see the digital clubbing of the fingers and things like that. So one of the reasons why they're red, they're pink, the pink puffers. You remember this is polycythemia. The body's response to this chronic decreased ability to move oxygen and this chronic decreased ability to perfuse is to try to create more red blood cells, so they become polycythemic and they become red. They also retain CO2, which causes a red hue as well. Your primary goal here is going to be the relief of hypoxia and reversal of bronchoconstriction. So remember, with any of these chronic illnesses, emphysema, chronic bronchitis, these patients live with this. This is not something that, hey, they woke up and suddenly they have emphysema. So usually if they're calling you, it's because they're having an acute exacerbation of it and they've done the other things that they know to do. So in this case, our goal is going to try to relieve hypoxia, but it may not be by the conventional measures that we usually try to relieve hypoxia, meaning that we know that we try to get a SpO2 up to 94, 95, 96, but in this case, they may chronically live with a SpO2 of 89, 90, 91. Our biggest thing here is to try to increase oxygenation to the point to where they're comfortable and they don't continue down the process. With chronic bronchitis, I don't have chronic bronchitis listed right here, but with chronic bronchitis, this actually affects the goblet cells. I don't know if you remember the goblet cells. The goblet cells are the cells that release mucus. One of the ways that I remember goblet cells release mucus is that goblets hold fluid, right? Goblets, like drink goblets, hold fluid, so goblet cells release fluid. So this results from an increase in the number of goblet cells in the respiratory tree, and again, it's usually associated with emphysema. Now, one of the things with chronic bronchitis is that in order for somebody to actually get a diagnosis, a working diagnosis of chronic bronchitis versus acute bronchitis, which is something that can come as an inflammatory or infectious issue, is that they have to be sick for more than 3 months a year for 2 years. Now, why do I tell you that? Because I feel like I've seen that question before. In order for somebody to be diagnosed as chronic bronchitis, they've got to be sick more than 3 months a year for more than 2 years. Again, this is going to be, an issue with gas exchange, but in this case, unlike emphysema, so emphysema directly affects the alveoli. Chronic bronchitis doesn't affect the alveoli as much, but gas exchange is decreased due to the lower alveolar ventilation secondary to chronic inflammation in the airway. Now, with these patients, they are going to be chronically hypoxic. They also are going to have increased CO2, and this is going to cause pulmonary vasoconstriction. Oftentimes, both of these patients are going to have a history of heavy cigarette use. Now, one of the things with chronic bronchitis patients is that oftentimes the pulmonary vasoconstriction due to the increased CO2 is going to lead to what we call pulmonary hypertension. Now, this is important in one of the differentiations between chronic emphysema and chronic bronchitis, or emphysema and chronic bronchitis. Why? Because if you've got pulmonary hypertension, that means that your pulmonary artery is going to be affected, which your pulmonary artery is the transport of blood from your right ventricle to your lungs, right? So what happens if you start having pulmonary hypertension and you start seeing an increased resistance to the forward movement of blood? What's going to happen to that blood? It's going to back up into the right ventricle. The right ventricle is going to back up into the right atria. It's going to back up into the systemic circulatory system. So one of the things that we see due to right-sided issues is going to be the bloating or the edema, hence the name blue bloater. Chronically hypoxic, and they are edematous. Now there's also another disease process that comes along with this, and that's called core pulmonal. Remember, the most common cause of right-sided heart failure is left-sided heart failure. But in this case, we're going to have right-sided heart failure that's caused by the increased vascular resistance of the pulmonary artery. That's important when it comes to differentiating the two. We oftentimes might see ECG changes, right ventricular size, increased right ventricular size. Remember, you can see that as evidenced by really affecting the QRS complexes and things like that. Our primary management, again, for both of these is going to be relieve hypoxia and reverse any bronchoconstriction. With your chronic bronchitis, you're more likely to hear the diffuse wheezing and stuff like that. Albuterol may be indicated here. Other specific illnesses, pneumonias may be caused by infection, inflammation may be caused by aspiration, pulmonary edema. I've mentioned the cardiogenic and non-cardiogenic. We'll mention that a little bit more here in a few minutes. Pulmonary thromboembolism, pulmonary embolism affecting the forward flow of blood. Lung cancers. Now, there's several different types of lung cancers. I'm not getting detailed into the lung cancers. Pertussis, a disease that we honestly really shouldn't even have to be concerned about or talk about, but we do because vaccinations. Cystic fibrosis, which is a multi-system disease, but you see some major manifestations of increased mucus production in the lungs. Upper respiratory infections, RSV in children, maybe even common cold, the flu, things like that. Spontaneous pneumothorax, and then hyperventilation syndrome. Now, one of the most common causes that's tied with hyperventilation syndrome is going to be anxiety or hyperventilation, but we can't discount medical causes and just say, hey, that patient's experiencing hyperventilation just due to anxiety. So just real quickly going through some of the specific treatments here, interventions for your pulmonary airway issues, always going to be ensuring your airway. Two things here, ensure airway and figure out how to decrease your work of breathing. The body has a funny way of trying to help itself. Okay, so now I'm in a situation where I'm experiencing respiratory compromise, respiratory distress, maybe even going into respiratory failure. So what does my body do? It increases the things that actually are going to deplete my oxygen reserve and my energy reserve. It's going to make me breathe faster. I'm going to get anxiety. I'm going to just become very antsy. My heart's going to beat harder. All of this is going to actually increase the oxygen consumption in the body and the energy consumption. So we've got to do things to help get that calmed down. Provide supplemental oxygen, obviously, if it's an airway issue. But again, it's going to be important that you differentiate between, is it a diffusion issue, a perfusion issue, or a ventilatory issue? Because if it's a physical ventilatory issue, supplemental oxygen is not going to do anything initially. Because if the airways are blocked, you can give all the oxygen you want, but it is not going to help. Your bronchodilators. So in the field, obviously, we use our fast-acting, our beta-2 agonists, right? Our beta-2 sympathomimetic, albuterol. There are slow-acting ones, but these are going to be the ones that you see for home use. Advair discus, salmeterol, things like that. Other types of bronchodilators, you've got methylxanthines, your electrolytes. So this is part of your bronchoconstriction protocol. If you've got bronchoconstriction that is refractory to albuterol or other things, then you can do a MAG drip. Now, all the literature that you read doesn't really give you a clear reason why MAG helps, but it is shown to help. Then, of course, your corticosteroids, which is part of your treatment there. Now, we've got here listed methylprednisolone, hydrocortisone, solumedrol is another one, also Decadron or dexamethasone. And then your vasodilators, nitrates. When is the situation when you would give a nitrate? Pulmonary edema, right? You want to try to increase the container, right? You want to increase the vessel size so that the pressure is not as much. And also, your nitrates is not only affecting your pulmonary vasculature, but it's affecting your systemic vasculature. So in turn, it's actually decreasing preload, right? So it's opening up our vessels so we don't have as much blood coming back. And so therefore, that really helps with the movement of it. Restore fluid balance, especially pediatric and elderly patients. This is going to be important with things that have a fluid aspect to them. ARDS, asthma. So really, if you're treating a person for asthma, and especially if it's a situation where they're in status asthmaticus, then you definitely want to consider giving fluids along with your albuterol. Not only is the albuterol going to be there to help open up the vessels, but the fluid's going to help to break up that thick mucus. And then your diuretics. Now, of course, we've got CPAP. It doesn't physically through processes remove the fluid, but it pushes the fluid out, which is more of an acute treatment. But your diuretics, your main diuretics that are used in the field are going to be your loop diuretics because they work quickly. Not as quick as CPAP though. You've got Bumax, which is a loop diuretic just like Lasix. A while back there was a shortage of Lasix, so we had to go to Bumax. But Lasix, again, loop diuretics. The issue with your loop diuretics, though, is that they do affect the potassium and the electrolytes. Then, of course, support your ventilations. Bipap has actually been introduced into the Alabama protocols now and is really more of a comfortable mechanism for a patient to breathe, and it works by doing the continuous positive airway pressure. But with Bipap, you've got higher inspiratory pressures or eye pressures, and you've got lower expiratory pressures, meaning that they're not going to be breathing as hard against it, but it still provides that pulmonary splinting. And of course CPAP. And then obviously intubation if we are in a point to where we're in respiratory failure or respiratory arrest, but all of the interventions prior to that is going to be there for us to try to prevent intubation.